All right. So when I looked at the OTEP schedule, it said that clinical decision making was a topic. Um, and for AC or for the ALS providers, is that the OTEP schedule this month? At least it said so on the calendar. So it's kind of a philosophical topic as opposed to a protocol-based topic, right? So this is going to be a little bit of a different style than probably what you're used to. And I want to just kind of briefly touch on what critical decision making is, clinical decision making is. All of you know what it is because you do it all the time, right? And then I kind of want to walk through a recent case that came across my desk with some concerns about, hey, did this go the way it should be? There were some disagreements on how things should take place in the field. What's your perspective on this? And it was a very complex case. And I think it highlights the fact that there's no black and white answer to a lot of these concerns about what should we have done or what should we not do, or whose philosophy was the right philosophy at the moment, right? Because the truth of the matter is every case is a unique case, and it might be the same diagnosis, but it's a unique environment, it's a unique patient, it's a unique scenario, and everyone is going to have an individual approach, and that makes it really difficult to walk away and say, yeah, I think we did everything exactly the way it should have been done. Does that make sense? So I think it's more important that you have an organized way to approach things and you understand acuity, patient severity, how to organize your thoughts, how do we use the protocols, what are they there for. So I kind of want to go over all of that stuff, which is definitely a different topic than what we've had in the past, right? But it was on the schedule, so damn it, we're going to cover it. Make sure this is working. I want to talk about the evolution of a paramedic provider and the history of where did paramedics come from. Because I think not just as a filler, right? Not just a time filler to make the lecture longer, but I really do think that to understand your purpose as your role in the community as a paramedic, why these decisions are important, why your ability to think on your feet is important, you have to understand why you fill the role you do in the community. And I think it's kind of like people like to look at their ancestry to give themselves some sort of purpose, right? You say, where are my roots? Where am I from, right? I'm from the South. I'm from the Midwest. I'm from the West, right? Or I've got Scottish blood, or I've got whatever, right? It gives you some sense of identity and purpose, right? I think the same is the truth with your profession. And if you understand where it came from, what it grew out of, and the role that it fills and the purpose it serves, it kind of gives you a little more of a platform to have this discussion, a little bit of a concrete foundation to build this discussion off of. So I want to start with that. We'll talk about acuity. And a lot of that is just when you show up, are they sick, are they not sick? And we'll talk a little bit about that. We'll talk about the role of treatments and protocols, critical thinking, developing a differential diagnosis, and how this needs to be a fluid process and not a static process. So what my initial differential is when I get a call, you all do this, you start your differential diagnosis as soon as the tones go out and you get a chief complaint, you're starting a differential diagnosis. You're thinking about what are the things that this could be: unresponsive, seizure, right? You're rolling through your mind, what are the things that I need to do, what are the things I need to check? Subconsciously or consciously, you're developing a differential diagnosis. And that differential diagnosis is going to evolve as you move across the timeline of that patient encounter. You show up and you see something different than what you pictured in your mind, your differential diagnosis changes as well. And if it doesn't, if you're one of those folks who makes up your mind of, here's what the diagnosis is, I'm going to take all the information and just use what supports my diagnosis, you're going to fail, right? as opposed to I show up on scene, I had a differential diagnosis, now I'm going to modify that and adjust it, and I'm going to take what things support it, and I'm going to take things which don't support my original idea, and I'm going to reformulate my idea. I'm going to reformulate my differential diagnosis, and I'm going to be fluid in how I think, right? So by the time the encounter is over, it's not what my initial diagnosis was, it's what best fits after I've gathered all the information, right? And that's really the mature process of clinical decision making. So we'll talk just a little about it. And then I want to have this case review, this discussion. And I want it to be more in an open kind of dialogue format, not just me reviewing a case, because what I don't want is, this is not intended to be an M&M case. This is not intended to be a QI case. We might QI it later on or something like that. But for now, I think it serves as a great platform of what would you do? It's a complex case. What would you do? How would you approach this person, right? What are the priorities? And there's going to be differences in opinions on what should be done and what should not be done in some of these. And I think just a discussion about how to approach it would be reasonable or good. Okay. So, and I think, I don't need to reiterate this with you guys necessarily, but you're not a field technician. You are an extension of the hospital to the community, right? You are a provider, a healthcare provider in the community. You're not a field technician, right? You don't go through a checklist, although we use checklists. You don't go through a checklist and check the boxes and then drop a patient off, right? You're thinking, processing, formulating, treating. You're doing the field provider decision. You're going to face moments, critical moments, where you've got to make a snap decision. And your ability to do that is, you guys ever read the movie, read the movie? God, that's pathetic, isn't it? Have you ever read the book by Malcolm Gladwell, Blink? Talks about making snap decisions. It's a good book. He's kind of a unique writer, but it's a really good book that talks about essentially why your snap decision is frequently the right decision. And a lot of it has to do with the experiences you've had and how your brain tends to process things so that your first answer is usually your right answer. So when you read a test question, you get your first answer, it's like, I think that's it. And then you go back and change it, it's usually wrong, right? But if you go with your gut, why does your gut usually lead you in the right direction? And talking about so anybody who is looking for an interesting read, it's an interesting read, and it pertains to our profession of emergency care because we make snap decisions. And you want to know, am I going to make the right decision? Am I going to be in tune to making the correct decision? And how that process takes place. So we'll talk a little bit about that. And I think most importantly, do you learn from your past experiences? Do you learn from your past mistakes, particularly, right? Do you self-reflect? Do you go back and you say, I don't like the way that case ran? Or do you just go back and flip on the TV and watch the next show? Or read the paper? Or do something else where you don't review and rethink what just took place and process that, right? Because if you don't give yourself that opportunity to rethink and run through things, right or wrong, you're probably not going to improve much over your career. I mean, you'll have the occasional scenario where you're like, oh yeah, I learned something new, that's cool. But unless you're really thinking, did I do things right? If you don't reflect on these events and these encounters frequently, even the ones that don't seem like they're the most flamboyant case, right? If it wasn't the guy bleeding all over the floor, it wasn't the big cardiac event, it wasn't something else, it was rather subtle but interesting, complex, had to make a difficult decision there. Was it the right decision? And maybe nobody else is understanding or realizes the fact that you really struggled with the decision during the whole time. Maybe you're the only one who's aware, right? Everybody else was totally oblivious to it because you just made a decision and you went. You ever go back and you think about that? Was that the right decision? And pass it on to other providers, with your colleagues. You think that was the right thing? That's a really important tool to ensure that we actually improve on a day-to-day basis, okay? So a little bit of history. I don't know French. Larrey. Dominic Jean Larrey. Sounds French, right? Larry? Jean Larry, we'll call him. Who Napoleon called the worthiest man I never met. And this was the field physician for the Napoleon Army in the Napoleonic Wars. And he really was one of the first to really define the need for emergency care, evacuation, rapid access by trained personnel. So instead of just having soldiers go out and drag bodies off the field, these were trained personnel on how to access patients, how to field treat and stabilize, how to get them to higher level of care facilities, medical facilities, which in that time were probably just tents where they cut off your leg, right? Bite down on the leather and stuff, but that's an advanced medical facility, right? And for those folks that needed medical care en route to that facility, he really defined that. And the initial ambulance, this was designed to rapidly and efficiently carry patients, was called the ambulance volante, or the flying ambulance, 1797. So someone who said, this is one of the earliest, truthfully, one of the earliest people to fill that need of and you'll see that the wartime conflict has really been the driver for this, obviously, because you have massive amounts of trauma, right? You have a large volume of sick patients, and you have to take these people from a field setting to a place of higher medical care, so it's a perfect setup. And you'll see that the evolution of advanced life support, EMS, paramedicine, really rides on our experiences in wartime conflict. (1862), Major Jonathan Letterman, who was appointed as the medical director for the Army of the Potomac in 1862. Anybody read much about the Civil War? It's actually a fascinating period of history. In the North, the Army of the Potomac was like terribly organized. They had poor leadership throughout the early years of the campaign, as opposed to the Confederate Army, who had Lee, who was a phenomenal leader, a great leader, and a real wartime genius, essentially, knew how to rally people together. And that's why the Southern, or the Confederate forces really dominated most and were far more successful in the early years until Grant came along. And obviously the North had much better economic opportunities to fund and survive a long conflict in the South, and that's part of the reason that the South eventually didn't do as well. The North had just shitty leadership, is what it turns out, until Grant, who was probably an alcoholic and was at the bottom of his class, and I believe in what's the war college up in upstate New York, but not the stellar academic, kind of out in the frontier, a bit ballsy, and kind of developed a name for winning these campaigns that were taking place, and he eventually got put into that position. But he's really one of the only guys who had the ability to make good decisions. Everybody else just kind of hummed and hawed and never really made firm decisions, wouldn't commit or would halfway commit, and that was part of the early failures of the Army of the Potomac early on the Civil War. Not that you really want to know that, but it's an interesting period in history. One of the things that came out of the Army of the Potomac, though, is this advanced way to access and administer care and really evacuate sick folks from the field. So Remember, there's 2 battles of Bull Run in the Civil War. The first battle of Bull Run was a devastating loss. Lots of casualties on lots of sides, on both sides. Many folks were left on the battlefield to suffer for days and days, and I believe it took over a week to fully evacuate everybody. And the quote was from the National Museum of the Civil War Medicine is that the ambulance system in the United States had failed them, right? That was an abysmal failure. And shortly after this time, Major Jonathan Letterman was appointed as the medical director, and he took essentially Gene Barry, or whatever the guy's name, John Barreau, or the Frenchie on the previous page, this guy, John Leray, took his concepts and applied them to to what their resources were. And if you look at the Battle of Antietam, which is arguably the bloodiest war single episode, or one of the bloodiest episodes in American history, just over a year later, with 17,000 wounded, all of them were evacuated from the battlefield within 24 hours. So a remarkable difference in the approach, and part of it is the fact that it was organized, structured, and, which is not uncommon for EMS, particularly fire-based EMS, is they drilled. And he put together a series of training, and this is an episode after Antietam where they did a mass casualty training episode with the equipment that they have, and so this is his newly organized medical corps, and so you start to see this organized, formulated, well-trained group of people who really fill in this void of pre-hospital care. It wasn't until 1864 where we realized that, hey, this subset of people on the battlefield serves a very honorable role of caring for the sick. And at the Geneva Convention in 1864, it was essentially decided that they are not to be targeted at any time during the war. And this is really where the American Red Cross sign that kind of ubiquitous image, or not ubiquitous, but universal image of the field provider was recognized. And so these people were allowed safe passage across battle lines for care of the ill and injured. And it's if these folks are targeted during engagement, that's considered a violation of the Geneva Convention. So really recognizing that this role is critically important. It supersedes the violence, or the need for violence in the battlefield, which is really an interesting concept if you think, hey, we're going to just kill each other, right? We're just going to kill each other, and we're going to destroy each other till we come up with a solution here, okay? That's a pretty big commitment to make, right, to go to war. But then superseding that level of commitment is a commitment to say, we also recognize the fact that the wounded and injured need care. And we are going to preserve the dignity of the role of the providers that deliver that care. And I think it shows this universal respect and need for people who provide this kind of care, and the expectation that goes along with it of how valued it is. Early civilian EMS, so everybody says, well, this is working great in the wartime conflict, but man, we do a terrible job with these new automobiles, right? People are no seatbelt laws, no helmet laws, no whatever laws, probably lousy roads. It would be great if we could get the same sort of organization to address the civilian sector as we could the military sector. And in 1965, this was kind of the landmark white paper on accidental death and disability, the neglected disease in modern society, came from the National Academy of Sciences. And this was a landmark article that came out, and really a report more than an article. And this is one of the most famous quotes out of this, is that in 1965, 52 million accidental injuries killed 107,000, temporarily disabled over 10 million, permanently impaired 400,000 American citizens at the cost of 18 billion. 18 billion in 1965, which is like a gazillion now, right? This neglected epidemic of modern society is the nation's most important environmental health problem. So we address cardiovascular disease, we address smoking, we address obesity, we address all these healthcare crises. In 1965, we addressed accidental injuries and our lack of response to accidental injuries, right? Say in 1 year alone, vehicle accidents killed more than we lost in the Korean War, and in the past 60 years, more Americans have died from accidents than all of our combat wounds in all of our wars. Right? So citizens dying from accidental injuries with no system in place to really take care of them to the level that they've been taken care of in these wartime conflicts. And so it really was a call to arms to say, let's take our successes from the battlefield and let's bring it into the civilian sector, right? This is 1965. So we have some early efforts here. I think I have some notes on here about this is Bellevue Hospital in New York City. I don't know where that one is. This is somewhere back in the Midwest, Stratford, or back east, Stratford, Connecticut, or something like that. What the hell happened? So shortly after this came out, this guy, J.D. Farrington, who's a surgeon, published an article called Death in a Ditch. You can actually get this and read it. You can Google it, Death in a Ditch, Farrington. It's like 5 pages. Published it in the American College of Surgeons. And he took that, he was one of the drivers in taking that, this information here and really pushing the medical community specifically to develop systems where we could advance EMS care. And he's the first person to really develop a format for patient assessment, safe extrication, emergency care, a checklist for what vehicles are going to require, right? So if you're going to have an ambulance, here's what should be on your ambulance, okay? Here's how much of it you need, and here's what should be there. And it became the framework for our first AMT ambulance training AMT, which was the ambulance training program, which is kind of the predecessor to essentially NAEMT. But it's pretty interesting. They got pictures like very kind of 1960s, kind of like Boy Scout photos of, you know, how to take somebody out of a broken vehicle. How do you put them on a stretcher? How do you hold C-spine? It's kind of that very classic golden era type publication. 1969, President Lyndon Johnson, Committee on Highway Traffic Safety, said, let's create a national certification. So now this is gaining popularity, and people are saying, all right, well, let's make this a role, right? So Thomas Edison creates a light bulb, right? And then you get Nikola Tesla does sparks, and all of a sudden you're like, well, shit, we need electricians, right? There's a trade. So how do we put together this trade organization, right? Same thing with EMS. You're not, Trey, I know I said you're not, it's trades earlier, it's your providers. But there, you can see that there's this void that's being filled. Now, how do we guarantee that this void, if we value it, how do we guarantee that this void gets filled with the people who do the job the right way? Because we realize that it is an important job and it needs to be done very well, right? So they start to establish uniform standards. In 1970, there's a task force that meets to establish bylaws. Within 6 months, which I don't think there's any task force that's ever done anything in 6 months, they come up with the national registries of EMTs, and they have their first board of directors meeting. So they say, all right, the task force is done. The people in this room are now the National Registry of EMT board, and this is our first meeting. So this is the beginning, the birth of the organized profession of pre-hospital care. The first NREMT exam is administered to little over 1,500 ambulance personnel in 1970. This is not very long ago, right? I mean, some of you guys were alive then, right? I was almost alive. I wasn't alive. I was almost alive. But this is a young profession, if you think about it. It's been growing for a long time. There's been an identified need for centuries, really. But this, from an organizational standpoint, is saying we really value what is being done here. We understand that this is a critical role that needs to be filled in our community, right? It's a relatively young profession. And think about what's changed from 1971 till now, right? 12 leads, pre-hospital, 12 leads in the field. Stroke activations in the field. Intubations, right? I mean, there's an incredible amount of things where this profession has evolved, and every one of them is layering on more responsibility, right? More difficult decision-making processes, right? A more complex level of care as we develop, and now we're talking about community paramedicine and things like that. I mean, this is critical decision-making is layered in the history and the birth of this organization, right? Of this profession. And I think it's important to understand that when we talk about why we value critical decisions. Peter Safar, one of the early docs in pre-hospital leadership, said, you know, you president and committees and all you guys, you can sit there and you see this with every organization. I see this with the hospital. The hospital says, hey, here's what we want to be done. Right? Do it. Okay? You say, man, I got like a million things I'm trying to do. How are you going to help me fund this? Right? I got to train people. I got to get equipment. You tell me to do it, but you got to help me come up with ways to get it done. So Peter Safar says, EMS, the present state of EMS, despite all of that, is an absolute disgrace, primarily because of lack of organization, coordination, and clearly defined responsibilities and authorities. And this is the testament, or this was given in a legislative testimony. So he really kind of called out the powers that be that said, hey, you can define it all you want, or you can say we want to do it, but put your money where your mouth is, because if you really value this, we need some support. So they actually took it out of what was highway traffic and safety, under the leadership of highway traffic and safety, or whatever it is, transportation part of the government, and put it into health, education, and welfare as the lead oversight in the federal government. So really realizing that it has a more important role than just traffic, where it started, and traffic accidents with that original white letter, and clearly defined 15 areas where we need: 1, manpower, education, communication, training. Data collection was a big part, so that we can follow and track and improve and see really where our needs are at, and are we meeting the needs of the community. And it developed a bunch of grants for EMS systems, particularly rural EMS systems, to really take off and get what they needed to become effective in the communities that they were at. And as this started to proceed, there quickly becomes a class of, be careful how I word this because I don't want to there's a group of pre-hospital providers who really excelled, right? Who were more than just transport. And that became an obvious class of the paramedic, okay? Where there was a lot more decision making, a lot more critical thinking taking place, a lot more responsibility in terms of patient care. And so they said, we need to select this subset of the EMS population and really put a lot of effort into it. And that's where you start to see paramedic programs take off in the United States. Nancy Caroline, the mother of paramedics, the Freedom House Project in Pittsburgh, this was like one of the bad ghettos in Pittsburgh in the 70s. And in the University of Pitt, where these two are from, said nobody will go, police wouldn't go into the neighborhood. Okay? Police wouldn't go into the neighborhood, let alone pre-hospital ambulance wouldn't go into the neighborhood, and they had dismal statistics for survival with accidents, access to health care, etc. And so they came up with the Freedom House Project, and they developed the first paramedic curriculum. They introduced the use of a pre-hospital ECG, 3-lead ECG, and monitoring, and really, I think she developed the first pre-hospital intubation airway management strategies as well. But this is the original textbook for pre-hospital care. And this was 1979, right? And everything has been kind of layered off of this. But this was kind of a perfect example of how the community receives the profession. Nobody else would go to this community, right? It was very much underserved minority community that did not get adequate care, did not get adequate public services. People were afraid to go there, and they thrived in this environment. They were loved, accepted, successful, and able to really take paramedicine to another level that they probably would not have been able to otherwise, because nobody else was going to go there, right? Nobody else was going to go there. So they used that opportunity and succeeded. So why the history lesson? We talked about this a little bit. I think it's important to know where we came from. Where did we develop? Why has this role of a critical decision-making pre-hospital provider, why does it have such an enormous role in our community? You have to understand where our roots came from before we have that conversation, I think, okay? So I know it's probably a long-winded introduction, but I hope it kind of helps set a foundation for why you got to be good with your decisions. So, as a paramedic, you've got to be able to take medical treatment to the field. This requires knowledge, right? Sound knowledge, fundamental practices, anatomy, physiology, pathophysiology, pharmacology, right? You have to have a very broad and deep understanding of medicine, okay? And then you've got to take that out of the sterile environment of the hospital, which has more resources than we'll probably need, except when you absolutely need it, then you got to find it, right? It's in there somewhere. You just got to find the damn thing. And you're going to go into an environment where you've got limited resources, but you're going to take all that information to the community, to the field, and you're going to utilize it in that setting, right? And that is a special task, right? I think this is why there's such interest in community paramedicine and integrated health services and things like that, is because, or mobile integrated health, is because you guys that do this every day, that go into people's homes and deliver care, that's a unique trade, right? Almost every other part of medicine, they come to us, right? They come to us to get their care. You go to them, which is not always pretty, which is not always clean, which is not always calm and quiet, right? It's not sterile like a hospital. It's a unique environment every single time. When I walk in and I see a patient in room 8 looked just like room 8 did 5 years ago, last week, and with the last patient. Room 8's room 8. I know what to expect when I show up in that environment, right? You never show up in the same environment. Well, some places you go the same environment. That's realistic. But I'll bet it's a little bit different every time. This requires that you develop an accurate differential diagnosis and that you treat accordingly, right? Which is difficult to do in a high acuity patient with limited resources, and understanding that I'm saying I want a short scene time on critical patients, right? I want a short scene time. You got a sick patient, and you show up on scene and you say, this guy is sick. this needs to be done. A, B, C, D, E, and F. And, oh yeah, Edminster wants me to be here less than 10 minutes, right? So you kind of get squeezed a little bit into, I know I got to perform these critical tasks and do these critical assessments. I know I have limited resources to do that effectively, and I know I'm on a time crunch to get it done. That's a tough environment to work in. That's a tough environment to be successful in. Fortunately, the vast majority of the time, you're exceptionally successful. And if you look at how well you guys do in critical cases, let's look at stroke, look at STEMI, and the outcomes related to whether or not they decide to call you versus they decide to check in at the front desk in the ER, they're going to get care fast. They're going to get definitive care faster if they call you, right? I mean, that to me is a testament of your ability to work well in that very confined, restricted, difficult environment. So it may seem complex and impossible, but you do it, and you find a way to do it all the time. If I put a bunch of docs on ambulances and said, go out and get these people and come back, it would be an absolute shit show because we don't work in that environment, right? So you fill this very unique role that is critically important. So in pre-hospital care, we call it clinical decision making, but I think, truthfully, the stakes are always high. It's like walking in a landmine every time you go to work. You're navigating a landmine field, right? Just trying not to blow up, right? I feel the same way in the ER. But this is really a high risk, high reward, difficult environment. And as soon as you start to put your guard down, that's when you step on a landmine, right? And it's easy to put your guard down when I get a bunch of low acuity patients time and time again. You're like, is anybody sick going to show up? And before you know it, you realize, man, that patient 2 patients ago was the sick one, and I missed it. I had my guard down, right? So you got to be constantly on guard. I think it's all critical. So what's our decision making based on? One, it's knowledge, right? What's our foundation of knowledge? What are we working from? Where's our platform? Where do we get our education? How well were you educated? What are you doing to gain information, new information? The profession has evolved, right? The classes that we give to our medics now are different than the classes that medics got 15 and 20 years ago. There's more information that's there. Things have changed dramatically in 20 years of the profession, right? So relying on your initial education is not adequate. And we have programs in place like this, like OTEP, like all these other things to keep people at continuous education, right? To keep people on par with how things are changing and evolving. And that is critically important to how well you function in the field. And then what do you gather, what have you garnished from your experience? Because there's shit that I can't teach you in a classroom, and I can't tell you as a doc who doesn't work in the field that 20 years of experience of running patients will teach you better than anything a textbook will, the newest, most modern, technologically advanced paramedic school will never be able to teach you that experience can only teach, right? So what are you doing to maximize your experience? Because this is probably one of our greatest opportunities to get better, right? So you young guys, what are you doing to make sure that every experience you have helps you evolve to become better, right? And those of you that have been around for a while and been doing this for a while, have you started to get lax in this area? Have you really realized, are you really saying, you know what? I appreciate now more than ever the fact that experience is the most powerful learner. And I suspect that would probably be the case, right? But don't get lazy, anybody, myself included, with taking the opportunity to say our greatest tool in gathering knowledge and knowing information and being able to do this job well is our past experience. And then how do we take this and how do we apply it? It requires some sort of organization, right? You got to organize it. You got to prioritize it. I think one of the things that makes a paramedic more successful than one of the greatest attributes of a good paramedic, let me rephrase that. One of the greatest attributes of a good paramedic is your ability to anticipate, right? And probably a lot of that is based on experience, okay? You're like, I've had this before. I know what's coming down the pipe. And I'm going to be ready for it. Because when it shows up, you can be in a quandary trying to figure out what the hell happened, or you can say, I know that every time I intubate somebody, I need to keep tension pneumothorax on the back of my mind. So I have this little decompression needle. So when everybody's panicking and their SATs drop and their pressure tanks, and you say, oh, yep, it looks like you got asymmetric. I knew that was coming. Decompress the chest. For anybody who goes from negative pressure ventilation to positive pressure ventilation, right? That's something that I should anticipate. When you have a STEMI and you say, guys, it's a pretty damn good looking STEMI, I don't think I'm going to go in, right? I think AMR is probably good to take this one solo. And then you find out that they V-fib arrested in the back of the bus, okay? Because what do I know happens with people with ischemic myocardium? It's irritable. What does irritable myocardium do? It fibrillates, right? So they might look good, but I anticipate this person is high risk to decompensate en route. That's why we go with STEMIs. We know that people who stroke can deteriorate and they can need critical interventions en route. That's why we ride in on those. We know that trauma patients can tank precipitously. That's why we ride in on trauma patients. Anybody who's an alert, that's why we do these things. We anticipate that shit's going to get worse before it gets better. And if it doesn't, that's great. But sometimes it will. And I anticipate that. And so I make my decisions based on that. Action and reevaluation. And I think this is also very important. As soon as you say, well, that was a good case, right? And they're not out of your hands yet, you're probably setting yourself up for failure, okay? You should be constantly reevaluating. Did my interventions make the difference they should have? And if they didn't, how do I reassess the situation? How do I change my differential if needed? I always tell the paramedic students, always have at least 3 things on your differential diagnosis. Always. At least 3. You guys who have been in my classes remember me saying this. At least you better remember me saying it. Always have 3 things on your differential diagnosis, right? When you show up and an overdose is an overdose is an overdose is an overdose, and differential is overdose, 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 you're going to miss something someday, right? Or if I show up and it's COPD, 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 I'm going to miss something, right? And it could be any of the other causes of shortness of breath. Atypical angina in a diabetic female, right? It wasn't COPD, it was MI, right? So how often do you get a 12 lead on your COPD patients? I get a 12 lead on my COPD patients a lot because I've made that mistake before, right? They have all the same risk factors, right? They're all hypertensive, they're all smokers, okay? They all have the same risk factors as people who have heart attacks. So if I just assume that everybody who is a COPD exacerbation is a COPD exacerbation, well, I didn't put at least 3 things on my differential diagnosis. If it doesn't make my differential diagnosis, it doesn't get diagnosed. If it doesn't get diagnosed, it doesn't get treated, right? So part of that too is, all right, you look like a duck, quack like a duck, walk like a duck, or whatever the thing, but when I listen to your lungs, you don't sound like COPD, right? You're supposed to wheeze when you're COPD. You're not wheezing, then I got to change things. I got to evolve. It's got to be more fluid, right? So you got to organize, prioritize, anticipate, act, and reevaluate, okay? You've got to be able to gather, evaluate, and synthesize a lot of information in a very little bit amount of time and develop your field diagnosis. Part of this is based on acuity, right? Severity when you show up at the scene. And we have a couple of ways. This is the common phrase for kids, right? sick or not sick, and how do you define that? If I sat here and you'd never had, this is like your first class in pediatric pre-hospital care, and I think this has happened with the medic school classes before, and you throw out the concept of sick and not, well, shit, it happened to me in med school. And the first person to say, might have been my dad, were they sick or not sick? It was like, well, what the hell does that mean, right? I guess they're sick, but what the hell does that mean? Sick, not sick, right? But we've all said that before. You know what that means. It's hard. You can't really define it. I mean, I suppose we could really define it, but that takes away from what it is. So when I walk in, are they sick or not sick, right? That's that kind of gut acuity. We say that a lot with kids, but it's the truth. It's the same with everybody. Sick and not sick. And a lot of the time it's just the gestalt, right? You walk in, that guy's sick. Okay? You walk in, they're not sick. Okay? AVPU is the other kind of way that we use to define this. Are they alert? Are they verbal? Are they response to pain? Are they totally unresponsive, right? So there's some ways that we can kind of gauge this and define it. But truthfully, what it boils down to, when we walk in the room, we say sick, not sick, right? And that's an experience, probably largely experience-based concept that you can't really teach, but you will pick up very quickly once you get into the real-life setting here. Before we get into, let's just take a 5-10 minute break, okay? And then we'll come back and we'll talk about some of this other stuff. Okay, so acuity. And again, we talked about this. A lot of this is just your gut, right? You show up, sick, not sick. You can really break this down into what are my obvious life threats, what are my potential life threats, and what are my non-life threats, right? Obvious life threats are pretty apparent. We tend to do very well on those because we're firing on all cylinders, right? You've got major multi-system disease, trauma, sepsis, sick patients, right? Devastating single system disease, ACS, stroke, big pulmonary embolus, trauma, right? Single system trauma like a pneumothorax, or decompensation of end-stage disease, bad CHF exacerbation, bad renal failure patient with hyperkalemia, bad COPD patient, right? These are our sick, obvious life threats, and we're totally dialed in on these, right? Everybody's on board. You got a plan. You've prioritized these people. You know how to approach them. I think the more difficult ones are my potential life threats, kind of that gray area. You walk in, you're like, they could be sick or not could be sick. That's really where you find that gray spot that's hard. And it's generally chronic disease that is layered on top of something acute, right? So just run-of-the-mill pneumonia in a 30-year-old is probably not a big deal, right? They're going to come in, we're going to get an x-ray, we're going to give them some cough medicine, we're going to get a little antibiotics, and they're going to go home and they're going to feel better in a week, right? But when I start to layer pneumonia on top of COPD, then I get somebody who has potential to decompensate with standard treatment, right? And if I don't address their underlying condition in addition to their acute condition, they go from what is probably a non-life threat to a serious life threat because of decompensation of chronic illness. These are the ones you've got to be very careful. Now, how many of your patients have COPD? How many of your patients have CHF? How many of your patients have chronic liver disease, right? And this makes up a large population or a large proportion of our patients, particularly the geriatric population, right? A lot of them have chronic medical conditions. So MI and CHF, what happens if I'm working with 30% or 35% ejection fraction, then I have another MI? Now I'm down to 10% ejection fraction. So what looks like decompensated CHF, I got to consider, well, what decompensated this person's episode? That's why important questions in this whole critical thinking process are, what caused the decompensation? You always got to be asking yourself, what caused the decompensation for chronic conditions? It's a big thing where we miss opportunities to capture an acute illness, right? So if I show up and I say, yeah, it's CHF exacerbation. Guy's got CHF exacerbation. It's always, right? I run on him a bunch of times, okay? Every other time, he's not taking his Lasix, or he just got done on a peanut and beer binge over a weekend of college football, right? I have some sort of explanation for the decompensation, right? So someone who's a COPD patient who is now with URI symptoms or is out of their medications, right? But if they say, no, I swear to God, I know I'm like bad about taking my meds, but lately I've been really good. I'm taking all of my meds the way I'm supposed to take my meds, right? That's a red flag, okay? That's a question you need to be asking. Do you have dietary indiscretions? What are you eating? Are you eating peanuts? Are you eating saltines? You got a bunch of salt? Because I know last time we talked, you were eating stuff you're not supposed to eat, and that's why you went into heart failure. No, that's not it. I swear I've been eating what I'm supposed to. I'm limiting my fluid intake. I'm taking my meds. Well, how fast did this come on? It came on pretty quick. It came on over the course of about 3 hours. That's different than somebody who is a slow decompensation because they're not taking their medicine. I've had worsening shortness of breath over 3 days, and now I'm like fluid overloaded and I got swelling. Well, are you taking your Lasix? No, I ran out 3 days ago. Right? They say, no, I've been doing everything, but now I just kind of, feels like my CHF is worse. That's something different, right? Then I got to worry about acute coronary syndromes in that person that I'd otherwise miss. So understanding the role of chronic conditions and how they can just decompensate on their own and be bad, or they can be kicked over into a decompensated state by another acute condition is an important thing to distinguish. And the only way to get that is by a good history. And the only way to get a good history is by having a good foundation of knowledge and experience to address these people with. Chronic liver disease, what's the problem with dead livers and trauma? Clotting. Where do I make my clotting factors? I make them in my liver. If my liver's gone to shit, so is my ability to clot, right? So, people who drink rarely have traumatic injuries, right? It's like unheard of to pair alcohol with trauma, okay? But that might happen somewhere along the way. So this is a bad situation where I'm just focused on the trauma. I may underestimate the impact that it has on somebody with chronic liver disease. So these are things to really think about. My methamphetamine addict with chronic renal failure, right? So what do I know meth does? It like dries people up like a little prune, right? They've been tweaking for 3 days. Their heart rate's 130. Their tongue is dry like a cracker, right? They've sweated all their sweat out. They're in renal failure, acute renal failure on top of chronic renal failure. You got to worry about these people. Hyperkalemia, right? You might miss hyperkalemia in this tweaker because you didn't take into consideration the fact that he's got chronic renal failure, okay? Same thing with the little old lady who fell down and broke her hip. I've used this example a number of times. Little old lady falls down, breaks her hip. You get a welfare check call because no one's heard from grandma in 3 days, and you show up and she's on the bathroom floor and she's altered. She's bradycardic. The room smells like urine, but everything is dry because she stopped peeing. Now she's in acute renal failure. She's been laying on that side of her body for the last 72 hours. Probably has necrosis of those muscles, rhabdomyolysis. And you put on the monitor and you see a wide complex bradycardia and an altered patient, and you say, well, you've got a tuber. GCS is less than 8, right? What's your go-to? Succinylcholine, right? Oh. man, I just tubed her and she died, right? There's an example, Russ, of tubing someone with sucks when they die, right? Is unanticipated or unidentified hyperkinetic. But these are people, you got to be careful of those folks, right? Those are people who are borderline that without you being on top of your game and without you really approaching it with the ability to make good, complex decisions and ask the right questions. Ask people about urine output. It's an underutilized question. What's your urine output? Oh, it's fine. Well, like old men like to talk about how many times they get up and pee in the middle of the night, right? So how many times do you get up and pee in the middle of the night? Oh, at least twice, right? How many times you got up and peed in the last 2 days? Oh, I guess I haven't gotten up in the last 2 days to pee. I actually slept pretty well, right? That's not an indicator of good health. That's a decrease in urine output, and that's a direct reflection on kidney function. So those are important. We ask kids that, babies that all the time. How's their urine output? How's their urine output? But we stop asking when they come out of diapers, right? It's a good question to ask through all stages of life, particularly when they go back into diapers later on, right? It's a very important question. And then non-life-threatening events, isolated minor illnesses and injuries, which are the trap of emergency care, right? I think the best analogy for why we do this is just like addiction to gambling, right? You see these people and they sit in the casino and they pop quarters in and they pull the lever. They don't have the lever anymore, but they run the cycle over and over again. And every once in a while, they get a payout, right? Every once in a while, we get a really good case. You're like, that was a great case, right? And then maybe you get another one 2 cases later. And then you go on a dry spell for 3 shifts. And then you have another great shift. And then you get another great shift. You get this random reward pattern. You don't know when it's going to get a good one, but when they come in, we love it, and that's what gets people addicted. Random reward, right? And really, if you want to get somebody addicted to something, random reward is a great way to do it. And that's how gambling is so effective. But our profession is a lot like gambling. We come in, we plug in our quarters all shift long, we expend our energy, we expend our compassion all day long, right? I came to work with a finite amount of compassion, I spent it all, so now I got to go home, right? So I plug my compassion quarters in, I pay out every once in a while, and I love this job, and sometimes I walk home and I think, man, I just burnt all my compassion. What am I going to tell my wife, right? So I think it's a reasonable analogy, and you've got to be careful that we're not missing some of these episodes waiting for that big event, right? We wait for that payout, but make sure that we're not missing some of these smaller rewards along the way, okay? What are your tools in the field? Protocol, standing order, patient care algorithms, recommendations intended to guide initial treatment, right? And this is a standard that includes general and specific principles for managing certain patients. In general, these are developed by a local EMS governing body. So for BLS level care, it's the Department of Health. For ALS level care, it's our EMS and Trauma Council. And we have a protocol committee. And we review protocols, we update protocols, we come out with new protocols. Guess what the new protocol that's coming out is going to be? You could have one drug that you don't have now, what would it be? Ketamine. We're coming out with a ketamine protocol, okay? I think it's safe to reveal that at this point. Yeah? Safe to reveal, you think? With ketamine. I'll bring the ketamine. We'll have a party. So in general, it's developed by a local governing body, and that's the Spokane County EMS and Trauma Council, right? Question is, how well do you know your local protocol? And it's your responsibility to know your local protocol so that you can operate within a system that has been developed for you to succeed in, right? But I want you to remember the first page of the protocols. Damn it, did it not make it in here? Okay, we'll get into that. I'll get off my soapbox for a sec. Treatments outlined or approved for immediate implementation. Remember, you are the arm of the hospital. By law, you have to operate under physician guidance, right? If you don't want to do that, go on to medical school. And I think there is a number of you who could easily succeed in that environment. If you're not happy where you're at, I think any number of you guys could go on and do that. But as long as you are a paramedic, you have to operate under the guidelines of a physician, right? So this protects you in a litigious environment that we presently live in, and it helps define and guide care in the field, okay? But it is not black and white, and there is a lot of gray area, and that's where good judgment comes into play and the ability to make critical decisions. Here are my tools when I show up to work and I open up a toolbox. Here are my tools. What's the best tool for this job, right? And you've got to make those decisions because you are equipped with a big toolbox, so to speak, okay? And standing orders are, just really is evidence of the trust and the value placed on the role of the pre-hospital provider. To say blindly, I want you to take this bag of medicines and I want you to go out there without me and I want you to take care of people that are really sick and bring them back, okay? And the community needs that. They expect that. They require that. They will pay taxes to have that, right? Because that's really where your reimbursement comes from, is this service that you provide to the community in the form of taxes, the vast majority. That is the expectation, okay? And there's a lot of trust that goes into that. And we monitor that very closely, right? We QI, we QA, we review a lot of things. We look at statistics. We look at KPIs, key performance indicators. There's a lot that goes on that never comes over my desk, right? There's a lot of things that I don't see. I don't want you to know that. I want you to feel like I'm watching everything, but I'm not, right? There's an incredible amount of trust that I have in your ability to do your job well. And these standing orders are similar. This is all throughout the hospital. We use these. Triage nurses have them, right? So we have standing orders for the nurses in triage. Just start the workup. I don't want to wait till they get to me for me to see them. If you've got a hunch of what's going on, start the workup. It's more efficient. We can get some treatment started early. People don't have to wait 4 hours in the waiting room to start getting taken care of, right? So this is a common theme throughout medicine. Algorithms are nice for complex situations where you've got to have clearly defined endpoints, okay? I think it's more difficult getting somebody into an algorithm than actually utilizing the algorithm, right? And truthfully, these are some of our more simple, like pit crew CPR. It's an algorithm. ACLS is an algorithm, right? You guys are so good at pit crew resuscitation CPR. I could blindfold a group of you and say I could take strangers, people that have never met from the various agencies at this point, and say, here's 4 other providers from Spokane County. All of them are familiar with pit crew CPR. Go. And I'll bet you could do a clean, smooth resuscitation. It's an algorithm that you train, right? I think some of the more difficult algorithms are, how do I plug this person into it before I run them through it? Spinal clearance algorithm, right? Which we have lightened up on significantly on who gets spinal motion restriction, right? So who do we apply this tool to and who do we not? Because once I apply it to them, it's pretty easy to run them through it. The decision is, do I apply it or not apply it? So I think that becomes a more difficult question a lot of times. So here's a perfect example of a complex algorithm that you do time and time and time and time again, that really is just like, hey, what's my decision point has to be, what hospital do I go to with this chest pain patient, right? and this defines when a regionalized healthcare system where we have regions of, or hospitals or centers of excellence, right? We have primary cardiac, primary stroke, primary trauma centers. We want to make sure the citizens in our community go to the highest level of care for their complaint. That's up to you to get them there, right? So here's an algorithm to assist you in making that decision, right? I think the one where we probably have the most difficult time is our high-risk chest pain, because there's a lot of ambiguity there. Is the chest pain really chest pain that I think is ischemic chest pain or an anginal equivalent, right? Because then I got to decide, am I going to treat this like acute coronary syndrome, or am I not going to treat it like acute coronary syndrome? Because if I decide I'm going to, well, they go through the algorithm, they're going to be at a cardiac center, right? So again, not black and white. Although it looks black and white, am I going to call it a stroke or not a stroke? And if I call it a stroke, well, I got a very clear-cut thing that I do. Fast exam, LAM score. Who's using the LAM score, by the way? LA Motor Score, the stroke severity score, who's using it? Who's patched in with an LA Motor Score? Raise your hand. My goal is that within 6 months, everybody patches in with an LA Motor Score, and it is routine, okay? It is an advanced way of categorizing stroke patients and ensuring that they get to the best facility possible, which is probably no different when they would have gone in the first place, but what it does is it triggers us to get an interventionalist involved so that we have the option to get them extraordinarily unique care that otherwise is not available in a lot of places. It's available in Spokane, and people with these high stroke severity scores should be getting the best treatment possible. Deaconess and Sacred Heart both give it.
You want the FAST exam as well?
Yep, so a FAST exam is positive, and if I know the FAST is positive, they're having a stroke. How severe is the stroke? And that's the stroke severity score, the LA Motor Score, okay? And we're going to get our little checklist to you that have that in there so you have a quick reference guide, because it takes a little bit of time to get used to, but we'll have that, okay? So algorithms, standing orders, protocols, they're going to provide you with guidance, but it's not a cookbook. Pretty catchy, huh? The Firehouse Cookbook. Don't you believe for a second I don't think about you guys when I put these together. A lot of good recipes in there. Actually, I don't know. Guy looks like he can cook. Kind of looks like B.C. Redding in that picture, doesn't it? Kind of, a little bit? Don't tell him I said that. Okay, this is the beginning. This is the introduction to our local protocol. And you may have never read this or read it once, but I think it is a valuable statement. To fully understand these protocols, you must understand the philosophy of Spokane County's delivery of EMS. The protocol book should not be viewed as a rule book, but rather as guidelines for your daily practice. No amount of rules can supplement good judgment and good thinking skills. Okay? Thanks for ruining my moment there, man. Jesus. In order to develop good judgment, you must be allowed to use it. This privilege comes with responsibility for your actions. We have a QI process for accountability here. You guys know what our expectations are. You know my personal expectations of you. There's accountability involved with there. It's important that you develop a strong understanding of the reasons behind each protocol. With this understanding, you will be able to think your way through each call, not just follow a set of rules. This is all emphasizing the value that we place on your ability to make decisions in under pressure, okay? We developed a system where EMS responders are expected to use their judgment. However, the EMS responder is not independent practitioner, but rather an extension of the physician in the pre-hospital phase of care. Therefore, physician involvement is of paramount importance. I included this because I want you to realize, and I don't know if you utilize the medical control line for things other than end of termination, right? That is a support line. It's a dial a friend. Was that on like Who Wants to Be a Millionaire or whatever the hell it was? Phone a friend. You guys all have my personal phone number. I've given it to you at some point or another, right? And if you don't, it's 435-7099, okay? 435-7099. Put it in your phone. Put it in your contacts. If you have a question, you can call me. I work bizarre hours like you work. And if you have a question at 3 in the morning, you can call me, okay? If I'm asleep, I won't answer the phone. If I'm awake, I will answer the phone, okay? And maybe if I am asleep, I'll answer the phone. But I'm available to you as part of my job and my commitment to the agencies that I work for, right? To you guys, that I'm involved with pre-hospital care. So the times where you run up against a tough spot, which we all do, I routinely call people, consultants in the hospital all the time, right? Hey, I got this problem. What do you think about this? I do that routinely. I do not operate as in I make a lot of decisions on my own, right? And I do a lot of care on my own throughout the course of a shift. But I also rely on another pool of knowledge of providers around me to make decisions. And I know you guys do that all the time, talking with each other, but we value you and we want to be available to you. So if you don't reach me, or if you have a question that you want to talk to medical control, call medical control. Here's what I got. What do you think about it? Now, you know my feeling about how to ask about things, because a lot of pre-hospital, or a lot of docs in the community don't understand the pre-hospital system as well as they should. So you guys are a very good, intelligent group of people, and the vast majority of the time, your gut is going to be correct. So instead of saying, can I do this? I think the way to phrase it is, here's what I want to do. We'll be there in 15 minutes, okay? And if there's something alarmingly that doesn't fit, you will probably say, let's just hold off on that for a sec. But the vast majority of the time, it'll be, yeah, that sounds like a good idea, okay? That's your blessing for things outside of the protocol. Magnesium for the asthmatic, right? Calcium in a prolonged arrest. I don't know, I did it the other day. It's not in the protocol. I was like, well, what the hell? Let's give it a go, right? Probably just bought the guy 3 days in an ICU and a huge bill that his family's going to have to pay because he's not going to live. But, you know, sometimes we get a wild hair and you say, I'm going to try this. Someone called about double sequential defibrillation. I don't even think you need to call about that. But that's a great phone call to get, right? That's a great phone call. Can we do double sequential defibrillation? Sure. Why not? So there's some good evidence that it works. You guys ever done that? Anybody else tried that or done it? You do traditional patches, and then you do front-to-back patches, and you do, it's essentially a defib followed by a defib, or you do them at the same time, simultaneous. It's kind of like, but you don't reduce the dose. You use the same amount of joules. Yeah. Double sequential defibrillation for the refractory VFib. Look it up. Read about it. That's the educational component, right? The continuous education we were talking about earlier. You run across these things, look it up, read about it. Look for the opportunity to use it. Start getting yourself familiar with ketamine. We'll talk about ketamine, but start to get familiar with it because it's going to become available to you shortly. All right. I'm going to just kind of cruise through here. This is thinking, develop a routine mental checklist. Use a focused and systematic approach. Utilize tools to help alleviate stress. We have this clinical checklist thing that we're putting together for you in high-stress situations where it's a quick reference guide that's not technology-based, so you can manually use something that is tangible, which a lot of people like. It's going to have a lot of our, the stroke severity score, the dopamine drip chart for drips per minute, because I don't want you trying to calculate dopamine drips per minute at 3 in the morning in a stressful situation on a teenage kid who's 42 kilos. You know, it's not the way we operate our finest, right? We rely on tools to help us. So rely on those tools. and then use your team to succeed. Okay, differential diagnosis. Interpret your data, apply your principles, evaluate your response to treatment, and then reflect on it. Again, anticipation. I think your ability to anticipate is probably the greatest predictor of success in this profession above anything else. And the ability to anticipate comes with a knowledge of disease and how people die and how people survive, right? And experience. Even if your differential doesn't make your final diagnosis, it doesn't become part of your documentation, it's still an important process that needs to take place, right? So I might just say at the end of my shift that this guy's got, or the end of this treatment phase, that you came in, you had chest pain, shortness of breath, cough, sputum, fever, you got pneumonia. That doesn't reflect the things that went through my mind as I got there. Now, I might put in some caveats in there that really kind of highlight some medical decision-making things that really highlight how I got there. But in general, there's a lot going on that doesn't make it to the document, right? But that's important. It's important that I'm thinking a bigger picture, that it's encompassing a lot more thought, and I'm putting what's relevant down on paper. If I put down everything I thought on every patient, it would be a freaking mess, right? Because there's a lot that goes on. But you got to be able to organize that and then report what's relevant. It's going to influence the questions you ask. Am I going to ask a lot of questions about your stool? Am I going to ask you a lot of questions about your chest pain? Am I going to ask you a lot of questions about your travel, your social history? A lot of that depends on my differential diagnosis and trying to tease out that top 5 or 6 things that are on my mind. How do I shuffle that list and prioritize what's the most dangerous, the most relevant, and the one that I should be treating first, right? The only way to rearrange that list efficiently is a good history and a reasonable exam. And I think the history is far more important than the exam. Far more important. Sometimes I feel like, truthfully, I shouldn't say this. Truthfully, I feel like sometimes the exam is just a way to get buy-in from the patient, that they actually trust me. I shouldn't say that. I still listen to them. Heart, lungs, press on their belly, press on their legs. The truth of the matter is I got my top 3 based on my history. And I'll listen to a couple of things that are going to help me shift this differential diagnosis. But the reality is I could probably treat a lot of patients without examining them, except in trauma. Except in trauma. And that's with a good historian. A couple of caveats there, right? But your history is your most powerful tool. And that is your greatest, that is the most efficient, most powerful way to develop an accurate and good, robust diagnosis, okay? If it doesn't make your differential diagnosis, it doesn't get diagnosed. And if it doesn't get diagnosed, it doesn't get treated, okay? So have a broad differential diagnosis. So here's an example. Patient A, patient B. 54-year-old male, shortness of breath. 54-year-old male, shortness of breath. You walk in, you see him tripoding and speaking in short sentences. What's on your differential diagnosis? COPD. Asthma. Any of the obstructive lung disease process. Allergic reaction. What else? PE. What else? CHF. What else? Pneumonia. MI. What else? Pneumothorax. It's anxiety, right? Any of those things, right? So, let's ask some questions. Patient A, sudden onset. It's lasted 30 minutes. It also has sharp pain, which is pleuritic, worse than I take a deep breath. Not a smoker. No fever, nausea or vomiting, no similar history. What's my differential? PE. What else? Tension or a spontaneous pneumothorax. What else? Pleurisy, right? A non-life threat. Okay? Patient B, gradually worsening over a day and a half. No chest pain. Heavy smoker. No fever. Yellow-green sputum. Similar episode 2 months ago. Pneumonia. What else? Chronic bronchitis, COPD exacerbation. Asthma. Right? So you start asking good questions. You start a good history, and all of a sudden you've got a major divergence and how people present. When I walk in and they look the same, they've diverged just based on a few quick questions that I can ask, okay? And if I'm not investigating that thoroughly, I'm not going to get to the correct treatment process at the end. Patient A, heart rate's 120, respiration's 25, blood pressure 95, diminished breath sounds on the left, JVD, tracheal deviation. Pneumo. Okay? So, quick assessment, good understanding of pathophysiology, how to apply that, how to look for key physical exam findings. What's the treatment? Needle decompression, right? Patient B, pulse 120, respiration's 25, blood pressure 175 over 90, diminished breath sounds throughout, prolonged expiratory phase, no JVD, no peripheral edema. Asthma, COPD, right? Relatively similar vital signs minus the blood pressure. Some key characteristics of where I'm going to focus my exam. I distinguish it from CHF. Instead of administering nitro and BiPAP or CPAP, I'm going to give them a duoneb and CPAP, right? This one I'm going to needle decompress. What if I pop this guy on CPAP? Right? But I'm going to just take this guy who's looks like this COPDer that I just had, and I'm just going to put him on CPAP because that worked last time, right? Well, you get a resuscitation out of the deal, right? The work you do now will impact your performance in the future. Didactics gives you a good, sound foundation of knowledge. Experience provides you with an opportunity to refine and perfect your trade. You will get as much out of these opportunities that which you put into it, right? Do you put in the bare minimum? This is a question to ask yourself. Do you put in the bare minimum on educating yourself on your profession, on the EMS side of your profession, right? Do you only do it when it's reimbursed, right? How much do you self-initiate? How much informal education do you prefer or pursue? Do you do case follow-ups? How frequently are you inquiring about cases, people you saw, trying to get follow-up? That is continuous education. How often do you read journals that are specific to what you do? How often do you listen to webinars? How often do you listen to podcasts, right? I get periodic emails from some people who said, hey, I just watched this Amo Matu video. You guys ever seen Amo Matu, the 12-lead guy? See, that is informal, non-reimbursed, continuous education. And listen, I'm not going, I gotta be careful what I say. I'm not going to a shitload of meetings that I'm not going to get reimbursed for, right? I'm a professional. I expect to be reimbursed as a professional when I do things, okay? So I'm not saying that you should show up out of the goodness of your heart and just learn as much as you can, right? I'm a professional. I expect to be treated like a professional. That means I get reimbursed for certain things that I do, okay? But I also do a lot of this stuff that's on my own time because it's valuable to me and there are opportunities to learn. And I don't get reimbursed for this, but I know it's making me better. Right? So how often are you doing these informal things? Okay? I think our evolving QI process is a great way to show or to apply this experiential knowledge and to refine how we do things. The way we've tried to do this is through our just culture approach, which is not the traditional M&M is you essentially get crucified in front of a group of people and shamed into doing the right thing. That's the kind of the medicine tradition of M&M, right? And in residency, you would present your own case that you effed up on, and you would have all of the experts in the various fields sitting in the front, all your colleagues sitting in the back, and you would get crucified on how come you didn't do this, didn't do this, should have done this, blah, 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 blah. Like, because I suck at my job, that's why. And that's how you feel when you walk out, right? There is a lot of motivation to not have to present your case at M&M. And it's not interesting cases. Like, that's for fun lectures. M&M is not where you want to be in the hot seat, okay? Morbidity and mortality. That has changed dramatically in the last 10, 15 years, okay? This is the new approach. And this approach is a productive approach. It's a way of saying people make errors, right? We know that bad things happen. Bad outcomes occur. We are imperfect. We all strive to do better. Was this error a reflection of how our system could be improved, right? And so the opportunity is to look at these cases and say, how can the system be better as a whole based on this experience? It doesn't mean that there's no accountability. There's still accountability for the things that happen, right? You're held to a very high standard. I will hold you to a very high standard. I think your peers hold you to a very high standard. My goal is that instead of me and Mike Lopez looking for cases, that you guys start to bring cases to us, right? That case where you say, I didn't sleep last night because I got home from work and I couldn't forget about what happened. I can't sleep. I take it home with me. It impacts how I deliver care. My confidence has been shattered. We've all been there, right? This is an opportunity for you to take that off your chest, put it out there. It's like confession, right? You go to confession, and you walk out of there, I think. This is what happens when you go to confession. Otherwise, why would people go to confession? You got to feel better afterwards than when you went in the booth, right? So you lay it out there and you say, let's talk about this case, right? Let's open this abscess. Let's drain it. Because as long as it sits there unaddressed, it festers and it gets worse. So let's take this bad outcome that I didn't like. I walked away from this case and I didn't feel good about it. Let's lay it out. Let's open it up. Let's drain it. Let's examine it. And let's see how we can improve as a system as a result. Okay? That's the goal. So those cases that you have, that everybody has, you have an opportunity to address them. And we've employed this several times now over the last couple months. Obviously, in the last few months, we've kind of fallen off on doing some of these because of, bad summer. But it's available, and we actually have a few on the docket that we're going to address. But I think that if you talk to anybody who's participated in one of these, they would say that they walked away from it feeling better about the case than when they came in, relieved of the burden, and felt like the system, we came away with a way to improve our system as a whole, okay? So send these to us. Let us know about these cases. It's a great way for us to learn from our mistakes, to make the system better, to make the experience less. You can't accumulate these things over the course of your career and not be affected by it, right? You can't. It's luggage, right? It's like viral luggage. It doesn't go away. You can't get rid of it unless you address it and you have an opportunity to do that. And this is trying to provide you guys with that opportunity so that, one, you don't carry that luggage, and two, we improve. Everybody gets better everybody has an opportunity to get better from it. Does that make sense? Okay. Okay. This is a case that was brought forward for the fact that it was one of those cases where you could tell that the crews involved were not entirely happy with how things went. Kind of like we were talking about. Okay? There were some disagreements on the philosophy of the approach between the fire responders and the transporting company, right? Which never happens, right? That never happens. So clearly what you get is a complex case with lots of critical decisions that need to be made in a restricted time frame with a critically ill patient. And there's no black and white response to this. There's a lot of suggestions that you can come up with, but there's no way that you can say the care should have been A, B, C, D, E. Right? It's a unique case with a unique environment and a unique patient and unique crew members, and you've got to make it through this whole scenario. So I'm not going to talk about what treatment was provided. I'm not going to talk about what was done during this case, and I'm not going to talk about the conflicts that arose from it, although I think the attempts to bring everybody together and address it immediately is exactly the way to deal with these things, and that's what the crews did. What I want to do is just walk through it in the next 5-10 minutes. And I just want this to be dialogue. Lecture's over, okay? This is dialogue, okay? So let's just walk through this case. Critical decision making, okay? You're dispatched 9:30 at night, a couple of days ago. It's 40 degrees outside, overcast. You get a phone call, 911 gets a phone call from a lady that thinks she just hit somebody driving down Highway 2, okay? She's pretty sure it was a human and not an animal, okay? So dark, unclear, can't find the victim, can't find the body. You show up on scene and there's a lady in her car, or lady involved in the accident, who says, with the police, and they say, we think she hit somebody, but we can't find them, okay? After 10 minutes of searching, they find him in the ditch/field, unresponsive. Okay? So, here's your patient. Here's your scenario. You can't see well. It's cold outside. You finally find them, and they're unresponsive. Okay? What's your first question when you walk in? Well, even before that, sick, not sick? Sick, right? On the scale of sick, 1 to 10, the potential for 10 is like pretty damn good with this story, right? Autopeds are lousy, okay? When I get an autoped, what is the mechanism of injury that you should consider? High and low, right? When I hear an autoped, this is my differential, right? I hear autoped, and I think high and low injuries. You see the guys that get hit in football, high and low? Okay, it's just like that. They typically get hit by a bumper, low, thrown onto the car, which usually is their melon against the windshield, or their neck, torso against and they get high-low injuries. So when I hear autoped, my differential starts with high-low type injuries. I expect an extremity fracture. Right? I expected a lower extremity fracture. I worry about vascular compromise. So that becomes a priority. This is just what kind of goes through. I expect head injury. I expect C-spine injury. I expect usually devastating head injury. I want to know if they're on blood thinners. That's going to be an early question. And whether or not I'm going to need to address an airway with spinal immobilization. So that's kind of my just first lines of thought. And that's before I even read. That's just autoped. Okay? And you guys probably do a very similar approach to that. What's my expectation? What's the mechanism? What's my differential diagnosis? And then I show up and I see sick and potentially really sick, okay? Then I've got the constraints of, okay, what do I know about really sick trauma patients? I need to keep them warm. What's the weather like? 40 degrees. Overcast, right? Potentially major trauma, 40 degrees. If he's bleeding, that's not helping. So temperature management is going to be a priority. What else? Time is critical, right? This isn't a post-arrest ROSC, sit on scene, 10 minutes, make sure you got all your shit together, right? Make sure that we have a departure, that when the public sees us, we look organized. We've addressed this. Dopamine's hanging, right? It's not it. It's like scoop and run, right? Get your shit together and let's go. Because generally, if it's bad and they're sick, it's OR sick, right? I don't fix them. The OR fixes them, okay? So that's that initial line of thought, right? So you automatically should be starting to prioritize things. So, AVPU, alert, voice, pain, unresponsive. So that's my first question. You said, is he breathing, right? Primary survey. You're starting to go through a primary survey, right? A, B, C, D, E. So he has partial airway obstruction. He's got shallow but equal breath sounds. Carotid pulse is present and regular. So what do I know about a carotid? I at least got a decent blood pressure, probably 80, 90, right? Or no, at least, I got that backwards. At least 60, right? So I got something perfusing, okay? GCS of 3, that's not good. Temperature, skin feels normal. There's a deformity to the proximal left leg. Blood loaded on the face and blood noted on the face and nares, okay? It's the high-low injury. Real consistent with a high-low injury of an auto pedestrian, right? Pretty immediate, quick primary survey, right? What's on your differential diagnosis? So H's and T's, what's going to kill this guy? In the next 10 minutes, what's going to kill him? Hypovolemia is definitely there. Hypoxia is definitely there. Hyperkalemia? No, off my list. Hypothermia, it sure as shit won't help if I address it. It's not the primary cause, but it needs to be addressed. Hydrogen ion acidosis, respiratory metabolic acidosis, probably not the driving cause. It's not DKA. It's not COPD, respiratory acidosis, so not a priority to me. Tamponade, maybe. Tension pneumo, maybe, needs to be addressed. Toxins, and unless you got high and walked into the middle of the highway, it's, never take toxins off your list, but it's low. Thrombus pulmonary, unlikely. Thrombus PE, or thrombus cardiac, probably not. I doubt the guy had a STEMI and stumbled out into the street and got drilled, right? So when I walk on scene, I've already narrowed down my differential diagnosis of life threats to hypovolemia, hypoxia, tension pneumo, maybe tamponade, and I have to address hypothermia, okay? So always be running these H's and T's on critical patients. What do I need to address, okay? 12 leads in medical patients, quick trauma surveys, listen to the lungs, a good circulatory, a good primary survey in trauma patients will address most of those things, okay? So, hypovolemia, that seemed to be on everybody's first list, right? So, where's my blood? Where do I look for, where can I bleed out? Where? Chest, abdomen, thighs, pelvis. Where can I bleed out? The environment, right? So if I don't see blood all around them, then it's in one of those 4 compartments that remains. I can't exsanguinate into my brain, right? There's not enough space. I can cause neurologic injury, which usually will result in hypoxia from not breathing, right? But it won't be exsanguination, okay? So how do I address? I focus my efforts on those things. I listen to lung sounds. I press on the chest wall, right? I press on the belly and see if the pelvis is stable, and I get pulses in. I can do that very quickly, right? So that's where I'm going to lose my blood. 2, can it be stopped? If I'm bleeding out, then I can do direct pressure. If I'm bleeding in my pelvis, I'm bleeding in my belly, I'm bleeding in my chest, right? Can I put direct pressure on that liver laceration? No. That's a problem I won't fix. How can I best manage that? Splint the pelvis to prevent expansion. What else? Let's say I'm bleeding into the belly. I can't stop that. I got a critically ill patient. How do I manage it? Go. Say it again. How are you going to target your fluids in this person that you can't control the bleeding on? Permissive hypotension, meaning I'm not trying to get a blood pressure of 130 over 80, right? I'm not looking for numbers. I'm looking for what? I want perfusion. What's the fastest way for me to get perfusion on somebody? Takes time to get a blood pressure, right? Radial pulse, and if it's available, mental status. That is targeted resuscitation, okay? I resuscitate to a radial pulse and mental status. I'm not dumping 3 liters in this person in 40-degree weather because I guarantee my IV fluids are cold. They're going to dilute, right? It's going to dilute their clotting capabilities. I probably start blowing out clots if I get blood pressures over 140 systolic, right? I want to preserve blood clot. I want to get perfusion, so we do targeted resuscitation. And is this someone who I'm going to stay on scene and do a bunch of stuff with, or is this someone I'm going to go? Someone I'm going to go. Because how do we fix bleeding in the belly? Operating room, right? Okay? So what are my barriers to hemorrhage control? Temperature, we talked about that. How well do I resuscitate this person? Are there other treatments that I need to address at this time? What about hypoxia? That was another one that was on there. What's the severity of the hypoxia? Is it primary hypoxia, meaning is this a tension pneumo? Is this a primary pulmonary injury, or is this secondary because they ding their head, right? Am I airway management because the guy's bleeding into his brain? Or am I airway management because he's got a hemopneumothorax? Okay, so where's my injury, right? And then my initial stabilization, do I want definitive airway management or do I want temporary airway management? And am I going to manage it on the scene or am I going to do it en route? Or am I just going to say, you know what? This guy's like clean shaven and he's got a nice jaw and I can just get the nicest seal and I'm just going to bag this SOB all the way in, right? And maybe that's the decision you make, but it's going to be based on sound, reasonable medical decision. And the fact that you had to make a decision, you made a critical decision in favor of time to mobilize transport, okay? Or you say, I don't feel like I can adequately address this airway. I feel like it's going to create conflict en route, that I'm going to have to address it. The GCS is worsening. He's vomiting. All these other, and I'm going to take the time right now and we're going to get a tube, right? Maybe that's the right answer. And it's hard for me, in hindsight, to say that was the wrong choice, right? Now, if I sit on scene and I say I wanted 2 large bore IVs, I wanted to warm them up to at least 98.6 degrees before we got there. I wanted airway management. I wanted to splint the leg. I wanted to clean them up, get the blood off the face. I wanted to present them in a nice package. I'm going to say you took way too much effing time on scene for this person, right? So there's a balance there. So, what are your priorities? You show up on a sick patient who's critically ill, who is on an acuity score, is sick on visual inspection, sick on primary survey, sick on the AVPU scale, right? You realize we've outlined the things that need to be done. We've developed a differential diagnosis. What are you going to prioritize? Because you can't do all of this on scene, right? Because I'm going to say, man, that was a 30-minute scene time. Is there anything that you could have done en route? Or did it all need to be done on scene, right? And I have one on the protocol test for when you research. One of the questions is, there is a complex medical patient. Anybody that's researched in the last couple of years, this has been a reoccurring question. I've kept it on there because it generates some good discussion. A bunch of things that need to be done on a patient, critically ill trauma patient. What's your expected scene time, right? And I have 5 to 10 minutes, and I have 10 to 20 minutes, and I have 20 to 30 minutes or something like that. And you get this, there's this, the people that put 10 to 20 minutes feel guilty The 5 to 10 minutes say ideally, but I know that can't be done. And it's the perfect dilemma. It's the question that's captured this dilemma of, I know I don't want to be there for a long time. I got a shitload of stuff that needs to be done. I feel like all of it's important. And then the next question is, which of those things can be done en route? Which ones need to be done done on scene? And it's a great way of saying, how am I going to prioritize these things, right? So what are your priorities? What absolutely has to be done on scene? Spinal immobilization absolutely has to be done on scene. Does anybody think that we can just ignore spinal immobilization in this patient? Okay. What about your trauma survey, primary survey? Does that need to be done? Okay. What would be your priority? How would you list these in terms of priority? As they are? Would you shift this list? I just put this list up there. I don't, maybe it was subconsciously in the thing of priorities to me, but.
A lot of those things are double, like you could be doing your trauma survey while you're doing your immobilization and putting
right.
spine. So I mean, a lot of those things are going to be overlapping.
And they should overlap.
Temperature management is as you're putting them in the back of the rig and getting them out of there faster. So I mean, a lot of those things are going to be happening because you can probably reduce by combining several of them in the same line item.
But all priorities. Okay? What if I told you you can't do all of them? What's expendable? Right? Because it's easy to look at the list and be like, oh yeah, we're going to do all of those. We're going to layer some of those things on top of each other, and we're going to accomplish all of them. But let's say you really got a time crunch. You're coming up against a difficult extrication that took 15, 20 minutes longer than you thought. You got a critical patient. You're realizing how cold it is.
Scratch the IV.
Okay? Scratch the IV.
There's too many parameters. It all depends.
Exactly.
We have to see the scene on.
Play the damn game, would you please? Just
Fracture stabilization is splitting that would be lower on the.
okay. Let's say he's got pulses in his extremity. Are you going to take the time to immobilize it? Maybe that's expendable. What if he doesn't have a pulse in that extremity?
It's still an extremity.
Okay. What if it's like pointing out here and it doesn't have a pulse?
So you can reassess, you can reposition it and check.
Okay, but it would be less important than how it would be done quickly and possibly en route. Okay? What else? What else is expendable? IV, let's say no IV. We're going to try and get an IV en route, and if we don't have an IV en route, then we're going to show up without an IV. And if we can't get that, we'll drill them. Right? That's a reasonable approach. Okay? What else?
I'd
honestly just throw a C-collar on them and throw them back and then strip them, and because by the time I don't know, it just takes too much time to backboard them fully, in my opinion.
Okay. Okay.
That's increasing your time.
He's out in a ditch, unresponsive. How are you going to get him from the ditch to the gurney?
Backboard or back saver, yeah.
Okay. All right. But it's going to be quick. Ditch the spider straps. Okay. All right. And it might interfere with your ability to maybe fully examine them in the back of the rig. Maybe getting them in the back of the rig without spider straps takes care of your environment problem, takes care of your limitations on assessment in a dark, cold field, right? And you can do it en route. Is it going to impair your ability to give the hospital an accurate message of what's coming in? Possibly. What happens when they fully get them and then you're like, hey, you didn't have a blood pressure. You didn't have time for a blood pressure. So when you show up, you've got this sick patient that you've been pressing to get to the hospital who doesn't have a blood pressure. And what's everybody say in the trauma bay? Where's your frickin' blood pressure?
He's got a radial pulse.
Okay, he's got a radial pulse, strong radial pulse. What else? Are you willing to sacrifice a blood pressure in a critical trauma patient?
I'd sacrifice the number for the fact that I checked
I would accept a sacrifice number for a radial pulse. I would make sure that that is communicated before I arrived, right? And some folks would say, I'm not showing up without a blood pressure. I'm not showing up without a blood pressure. It'll take me 2 minutes to get a blood pressure. I'm not going to walk in the room without a blood pressure. Was 2 minutes going to make a difference?
I think if I had those 2 minutes, I'd rather get the IV than the blood pressure.
Okay. But these are the difficult decisions. These are some of the things where the conflict arose on this patient. And we're not going to discuss what happened, but you can see where these things come up, right? In a complex patient where you've got to make quick decisions.
I think sometimes with the IV though, you get in the hospital, there's like 8 people that can do IVs.
Mm-hmm.
Sometimes you just don't.
I don't have an IV. We could still be in the field right now getting an IV if that's a priority. Most people, if you really communicate and you approach this with reasonable medical decision making and not apathy, which no one is going to treat this case with apathy, right? Nobody will. This is a great case, right? This is the kind of case you like. Trying to find the guy. We found him. He's sick. Got hit by a car. You know? This is a good case. No one's going to be apathetic about this case. Okay? So there's sympathy in the fact that this is tough. And I think we have to implore on each other a little bit of grace when it comes to these difficult cases where there might be disagreement to say, that's a tough case. We'll struggle through this one together. Here's what's happening. Here's what we did. Let's reflect on it. What could we do differently? Possibly. Not necessarily what did we do wrong or what do we disagree on, but what could we consider to do differently next time or in a different setting? What were our priorities? Were they the right priorities? You may not come to terms on it, right? But we've got to extend each other a little bit of grace to have a difference of opinion because you can see there's a lot of gray area in emergency medicine and pre-hospital care. The priority is that you're using your brain, you're doing what's right for the patient, you're making tough decisions that are based on a good foundation, understanding what your role is in the community, how important it is, and the importance you have on the outcome of patients bringing them into the hospital, okay? Make sense? Okay. Oh, this is the age-old question. Stay and play, load and go. Why do we treat trauma different than medical? I mean, this is a whole other discussion in itself. What can be reasonably accomplished in the back of an ambulance? Should always be a question, regardless of the case. What can you do to help facilitate these things getting done in the back of the ambulance? That probably would help avoid a lot of pre-hospital conflict if this was addressed together as opposed in silos, which frequently happens between fire and public-based transport or private-based transport, okay? So just think how you can be an ally, particularly in that gray area patient that maybe is a chronic condition that we don't know why they decompensated, someone that I need to be a little extra vigilant on, okay? All right, I went over. No surprise. Only 15 minutes this time. Any questions? Probably lots of questions. Very few answers. Yeah?
I just wondered on that case, it said partial airway obstruction. I was just curious what was obstructing the airway.
Probably a tongue, probably a little bit of, I mean, the guys, I mean, with the GCS of 3 and unresponsive, I would assume it's just tongue. There's some blood in the airway. When I looked at the hospital record, there was no obstructing foreign body. There was no significant, there were some facial fractures, but nothing that would be like an unstable jaw. So probably just, it was the headlamp. Yeah, it was the grill. The hood ornament was stuck right there. No, so I would assume it could be managed with basic airway management. And in this circumstance, the patient was not intubated in the field, and they elected to do BLS airway management, and it worked out just fine. And actually, the guy had a couple injuries. He had a liver lac. He had probably a urethral injury, unfortunately for him. And there was some minor facial fractures, but no head bleed. He became a little more alert. Obviously was intoxicated, as most of our pedestrian versus autos are. But the guy actually did relatively well, minus his jacked up leg, but he'll get the...
Did they use eye gel?
Nope. Nope. And en route, he became much more responsive en route. And so I think it was a good, reasonable decision to say, hey, let's just go and we'll manage this, and if it gets worse, we'll deal with it. So, okay. Thanks for coming. Sign in. If you didn't sign in so that you can get credit. Yeah.